Good afternoon, respected judges and colleagues. It is an honor to be here today. My name is Dr. Kannika Bureekanchan from Thailand. Today, I would like to share a case that demonstrates intentional planning from day one. One extraction, one implant, one stable smile. This patient is a 39 years old Thai female who experienced dental trauma following a motorcycle accident. She came to our clinic approximately 2 months after the accident, complaining mainly of a fracture involving tooth number 13. At the initial assessment, fracture of tooth number 13 were identified. Prior to visiting our clinic, the patient had received initial restorative treatment on tooth number 12. Clinical examination showed loss of tooth coronal tooth structure of tooth number 13 with pulpal involvement. The fracture line extends from the incisor edge toward the subgingival area with visible less pulpal tissue at the fracture site. Tooth number 13 remained in normal alignment within the dental arch with no clinical sign of displacement, intrusion, or extrusion from both frontal and occlusal views. After that, I sent the patient for a CBCT scan. CBCT showed a longitudinal crown root fracture extending below the bone crest. The buccal plate was extremely thin, 0.49 mm. Based on clinical and CBCT findings, tooth number 13 was diagnosed as a complicated crown root fracture and non-restorable tooth, indicating extraction and implant placement. Tooth number 12 remained restorable despite a crown fracture and discoloration. Endodontic treatment was planned. In this case, immediate implant placement was not a choice, it was the proper treatment. Immediate implant placement can shorten treatment time and help preserve soft tissue contour, especially interdental papilla, resulting in improved immediate aesthetic. However, it is a technique-sensitive procedure and carries a risk of mucosal recession, particularly in thin bone phenotypes. For this reason, precise planning and experienced execution are critical. The main challenge in this case was not simply replacing the tooth, but preserving the extremely thin buccal plate, which measured only 0.49 mm. A thin buccal plate is well known to undergo significant resorption after extraction. This case clearly represents a high-risk situation of post-extraction bone collapse. Given the extremely thin buccal bone, soft tissue stability became a key determinant of aesthetic success. While soft tissue augmentation is important, there are 4 key clinical benefits. It significantly improves aesthetic outcome of implant placement. Number 2, while it has a limited effect on marginal bone level, it enhances gingival health and support better plaque control. 3. A wider zone of keratinized mucosa help in reducing mucosal recession. And 4. Most importantly, it ensures stable clinical, radiographic, aesthetic, and patient-report outcomes over the medium to long term. Previous clinical study by Professor Khan et al. Have shown that connective tissue grafting performed at the time of immediate implant placement can increase gingival thickness and help maintain the gingival level in the aesthetic zone. Therefore, soft tissue augmentation was intentionally incorporated to reduce the risk of recession and improve long-term aesthetic outcomes. Today, soft tissue augmentation during immediate implant placement is commonly achieved using 2 techniques. The first one is the subepithelial connective tissue graft, or SCTG, and the second one is the de-epithelialized connective tissue graft, or DCTG. For the SCTG, this approach may result in less lamina propria because a part of it remains attached to the epithelial layer that we are trying to separate. As a result, the graft may become richer in adipose and glandular tissue. It may reduce the quality of the graft. For DCTG, is obtained by removing epithelium from free gingival graft. As a result, the graft may compose mostly lamina propria with minimally submucosa. It provides a dense collagen-rich structure. From this systematic review and meta-analysis at 1 and 5 years of follow-up, coronary advancement flap combined with de-epithelialized gingival graft show higher mean loose coverage, greater keratinized tissue gain, and better clinical attachment gain compared to coronary advancement flap with SCTG. So, clinically, this suggests that the de-epithelialized gingival graft approach may provide more stable and superior long-term outcome. Here a quick comparison of DCTG, SCTG, and soft tissue substitute. So in this case, I showed DCTG. So this case follow one fully integrated concept. Extraction of tooth number 13, immediate implant placement, immediate provisionalization, and soft tissue augmentation, all aimed at preserving hard and soft tissue contour and achieving a stable, long-term aesthetic outcome from day one. We use a tooth gauge to place the implant in a precise, prosthetically driven position. In this case, a Megagen BlueDiamond implant was selected. The implant features a deep and nice thread design, which provides excellent primary stability, particularly in immediate implant placement. A Megagen BlueDiamond deep thread implant I used diameter 4.1 by 13 mm was selected and planned to engage the palatal and mesial bone to achieve optimal primary stability. Let's get started. Tooth number 13 was carefully extracted using an atraumatic technique. After that, the surgical guide was tried to confirm proper fit and positioning prior to implant site preparation. After implant placement, we achieved excellent primary stability with an insertion torque 45 ncm. This allows us to proceed with immediate provisionalization. The provisional crown was placed on the same day, not for function, but to support the soft tissue, especially interdental papilla from day one. We shaped the tissue early, not after its collapse. This is the provisional crown used in my case, and it was designed based on EBC concept. The E zone is convex to support the gingival margin. The B zone is concave to provide soft tissue augmentation, and the C zone is straight to support crestal bone stability. This contour design helps guide soft tissue healing and maintain a natural emergent profile around the implant. After provisionalization, soft tissue preparation was performed. A labial pouch was created at tooth number 13 using a channeling knife, following the direction shown in the image. The graft was harvested from the palatal gingival. Subsequently, I removed the epithelium from the connective tissue graft. Unfortunately, clinical photos of this step were not available. I'm so sorry. So I will explain using this image. After the lip hole was created and the DCTG was secured, gap grafting was performed using xenograft to support the buccal contour and preserve the hard tissue. This image shows the immediate post-operative radiographic and clinical outcomes. Both enhanced soft tissue appear stable, and the results are consistent with the planned treatment. These pictures show a stable and well-balanced aesthetic outcome with good soft tissue support around the provisional crown. At 2-week follow-up, the sutures were removed. healing with no sign of inflammation, and the provisional crown remains stable with no mobility. At 6 weeks follow-up, the soft tissue remains stable and well measured. From the frontal, lateral, and occlusal view, the contour continues to appear healthy and well supported. At 4 months, this was the right time to take the final impression for the definitive crown. The soft tissue was stable and well measured. Shade selection was done intraorally to match the adjacent teeth and ensure a natural final outcome. On the X-ray, the bone looks stable and clinically, the soft tissue contour looks healthy. This is the result of controlling the hard tissue, soft tissue, and provisional restoration from day one. As you can see here, the emergent profile is very well shaped, stable, and highly aesthetic. This is exactly the goal of our approach, a stable, natural, emergent profile from day one. Now it's time for the final crown. This is the final crown in the frontal view, showing a harmonious and natural aesthetic result. This close-up view highlights good soft tissue integration and a natural gingival contour around the final crown. The lateral view shows excellent tissue support and aesthetic integration. This occlusal view shows smooth and continuous gingival contour, supporting a natural emergent profile. At 6 months follow-up, the clinical outcome remains stable. The soft tissue contour is well maintained with no sign of recession or inflammation, and the emergent profile remains harmonious in all views. Lateral occlusal view and lateral view. This one-year result confirmed that controlling hard tissue, soft tissue, and prosthetic from day one can deliver long-term stability in the aesthetic zone. Considering the initial buccal bone place was only 0.49 mm, this level of bone preservation is very favorable. At 1 year, the lateral and occlusal will remain stable and well supported. 1 year, stable tissue, stable aesthetic, one stable smile. Conclusion. From day one, precise computer-guided implant placement ensure ideal 3D positioning. Immediate provisionalization with de-epithelialized connective tissue graft was used not for speed, but to actively shape and stabilize the peri-implant soft tissue at the earliest stage of the healing, especially interdental papilla. With the EBC concept, a natural and stable emergent profile was maintained over time. This case showed that long-term soft tissue stability is not achieved by chance. It is the result of intentional planning. And when every step is planned from day one extraction, one implant, one stable smile. Thank you for your attention.